Hi, everybody, and welcome to DocTalk. I am Dr. Erin Knopf, and today I'm joined by one of my esteemed colleagues and someone I am so grateful to call friend, Dr. Neeru Bakshi, who is a wonderful psychiatrist and works at Headspace, but is also one of our wonderful advisors here at Very. And today we're talking about a topic that I know is near and dear to your heart as well. And I would love to have you start us off with where do we even begin to unpack this
Yeah.
concept of BIPOC mental health? And how do we even assess the current landscape, the future landscape needs, and
Mhm.
by also knowing how did we even get here? We're wondering how we got here.
Yeah, yeah. And you're right. Like there are so many different aspects to this that we could really dive into and be thoughtful about. And, I guess just a little bit of my own personal orientation to this is, you can obviously tell I am a person of color. And as I've navigated learning to become a doctor, then learning to become a psychiatrist, and then practicing, which I've been in practice now for longer than I want to admit. But that I've noticed and seen themes over the course of all of those different things. And then in the last several years have taken the time to educate myself, to do the readings, to change the way that I practice so that I can hopefully meet the needs of the people who come to see me as best as possible, but then also looking at the larger structures as they exist and trying to influence change in those structures. So, part of what I think is incredibly important is the historical, arc. And this, we could go back hundreds of years, we could go back thousands of years, but I think, oftentimes when we go that far back, we can often feel like, okay, then this is a remote problem. This is not something that happens in the day to day now, nor has it happened in a generation or more. But
It
that's
doesn't
really,
affect me.
really
It doesn't affect my perception of health and wellness.
right. But that's such a fallacy, right? Because it's a fallacy that we use to comfort ourselves to just sort of say,
Mm.
well, then this isn't a problem that I need to deal with. And that's not true. So some of the things that came to mind as we were preparing for this chat were just the variety of different ways that healthcare, physical and mental, both have negatively impacted BIPOC populations and caused
Mhm.
harm. And I think acknowledging that is so incredibly important because we don't acknowledge it, then we're really not serving the person who's in front of us when
Totally.
we meet with them. So I
Totally.
think, yeah, that's the arc that I like to take when I'm thinking about this issue.
No, I think it's so true. If anything, when we were in medical school, we're taught prevalence, incidence, epidemiology facts, all of this information without actually knowing where were these percentages derived from, nor were we really informed what was the scope of those studies and how
Mhm.
much bias or um, let's just say dehumanization was actually occurring in those
Yeah.
studies to give us this quote unquote medical information and facts.
Mhm.
And it is honestly appalling, I think, to some degree, to be at this point in my career. I know you and I've talked about it too, this far out of that initial medical school training to
Mhm.
realize these gaps that were existing
Right.
for us, even when we were acting as early providers and we didn't know what we didn't know,
Mhm.
even. It's
Right.
huge.
Right. And I think you're highlighting something so incredibly important in those research studies that we were taught on. Oftentimes, studies that were used to cite, like, these are the treatment modalities that should be used and whatnot, didn't include people of color, specifically
Mm.
Black people, Hispanics, Asians, hardly ever. And so, a lot of studies about what was considered normal versus abnormal were done on white individuals. And then
Mhm.
we were taught that certain conditions or certain ways that you measured things were different based off of race, which is not actually true, right?
Nope.
I remember as a resident, I was working in Houston, Texas. I went and did a consult on a patient that was physically in the hospital for cystic fibrosis. And we were talking about, as a team, without the patient present, how cystic fibrosis is more prevalent in the white population. this is not true. This is not based in any scientific fact. But what it leads to then is if for example, Black person were to come in with complaints that were very similar to a diagnosis of cystic fibrosis, they would often be told, well, but cystic fibrosis doesn't exist in Black people, so you couldn't possibly have that as a diagnosis. And it's like, wait, this is completely 100% not true. But then, as a result, right, pulmonary function or lung function tests, we were told there's a different scale for Black people than there is for white people. Kidney function tests, there's a different scale of
Yeah,
what's normal for white people, and there's a different scale for what's normal for Black people. And none of this is actually based in scientific fact. So, all of these things
exactly.
that we were taught about physical health weren't true. But then, what were we taught about mental health that wasn't true?
Exactly. And how much
Right.
of that physical health attitude and
Mm-hmm.
healthcare attitude affects the mental health
Right.
status of those in marginalized communities and,
Mm-hmm. Mm-hmm.
racially discriminated communities. I mean, that's
Yeah.
a huge thing of like, it really begs the question, chicken egg, when we talk about functionalities we see playing out today, how much of
Mm-hmm.
that is based in that historical context of distrust of the medical
Right.
system, of
Right.
just blatant ignoring from the medical system.
Right. Yeah. And, I think more recently we've heard stories of Serena Williams and her
Mhm.
experience in giving birth, and Allison Felix, the track star, her
Yes,
experiences with
yes,
giving birth. And these are people with platforms who are speaking about things that happen every single day, right? If your pain isn't believed, if your report of symptoms isn't believed, then how is it that we're building a system of trust? We're building a system of like belief that you're going to receive care that's actually appropriate. And what we also
totally.
see are, higher numbers of Black and Brown youth that are diagnosed with conduct disorders and oppositional defiant disorders when their behaviors are very similar to their white peers who don't have as many of those diagnoses. And we see
Mhm.
in school that higher numbers of Black and Brown youth are going to be suspended, expelled, taken to the office for their behaviors compared to their white peers. And so
Mhm.
this starts in childhood that we see these
Totally.
disparities. And, I just was having a conversation with a pediatrician friend of mine who I absolutely love and adore, but works in a suburban clinic and was saying, well, I don't see that with my patients because, they have a good socioeconomic status. And so that, these aren't problems. And I wanted to just be like, they are. Socioeconomic status doesn't protect against these kinds of biases and these
No,
systems that exist. You
totally,
may think that it does, but it truly, truly doesn't. And then we
totally.
extend this into adulthood. And one, there's this assumption that Black and Brown people are at a lower socioeconomic status than white people, which is
Yeah,
not true, but like, okay, we're going to make this assumption.
yeah,
And then there are these assumptions and these tropes that exist about sort of dependence upon the system and, welfare moms and, this, that, whatever, that are
yeah,
just not based in reality or fact. And
totally.
so when we have all of these systems that exist that then tell you your story isn't going to be believed, your report of your experience isn't going to be believed, and people are going to make assumptions on what you can tolerate versus not, right? Because there's also
Yeah.
this belief that Black people can tolerate pain greater than white people. So we don't need to give them as much pain medication, right? Like if all of this, your existence isn't believed, how are you going to trust a mental health care system?
And how is your mental health going to actually be protected and resilient, truly?
Right.
I mean, that's honestly the hardest part is just seeing that outcome. I mean, that is the, by definition, epigenetics and
Mm-hmm. Mm-hmm.
multi-generational trauma. Like this is accrued. There's a DNA level of internalized responses potentially, for anyone who's
Mm-hmm.
experienced multi-generational trauma. And no one more, especially in this country, than those who identify as being BIPOC. I mean, just
Right.
because of how profoundly systemic racism really is.
Right.
And again, it wasn't that long ago that it was excused as a reasonable and appropriate perspective. I
Hmm.
mean, that's
Hmm.
what's even scarier. Now we are much more honest with ourselves to some degree. you
Hmm.
know, as vulnerable and hard as it can be, we have to be. But it wasn't that long ago that things were happening that absolutely wouldn't fly today under any ethical consideration
Right.
for research formats. IRBs would not have been approved for these
Yeah.
studies, and yet they happened in our
Hmm.
lifetime.
Right. And, you and I were just chatting about the fenfluramine study from the
Mhm.
mid 1990s. And what that
1990s,
was,
everybody.
yeah.
1990s. Like, think of Clueless. Think of, these
Which for
things.
me, I'm like, that was 10 years ago. It wasn't 10 years
It,
ago, but
it wasn't. Are you sure?
that but what happened in this study was, from 92 to 97, these researchers from Columbia were trying to figure out, what the genetic understanding was of antisocial behaviors.
Mm,
And this was flawed from the get-go. They
totally.
decided to go to see, okay, who are the Black and brown youth that are in the incarceration system, in the juvenile justice system in New York. And then they got the probation department to give them information about those children's families. And the families then were contacted and said, we want you to participate in this study. We would like the younger siblings of these incarcerated children to be participants in the study. So there's coercion already there, right? Because if you believe that the probation department has some connection to this study, which they did, then you don't want to do anything that's going to jeopardize your child who's in that system. So you're
Totally.
going to feel coerced to participate in this study.
Totally.
Then what they decided was, okay, so antisocial behavior is related to bad parenting, and we believe that there is a low level of serotonergic activity, and so we want to make sure that this next, group of children who are the younger siblings, the younger brothers, we're going to see what happens when we treat them with something to increase their serotonergic activity.
And to
And the
clarify
medication,
too, that was just a theory that this is based off of
theory.
low serotonin.
Exactly, exactly.
Okay.
And bad parenting, right? So there's this
Yeah,
automatic
right.
assumption that Black and brown parents who have a child in the carceral system parented poorly.
Yeah.
And so we have to treat this, right? Because we have to figure out what's wrong in this
Yeah.
situation, not taking into account anything else. So these young children, these young boys, were given fenfluramine. This is a medication that was never given to children previously. It has known cardiotoxic outcomes, which means it negatively impacts the heart. And yes, it does increase the levels of serotonin. This is preposterous,
Totally.
right? That these children were experimented on. And this is often what has happened in medicine is this experimentation on Black and brown bodies being normalized. But
Yeah.
positive treatment outcomes or other studies were not included in those studies, but as experimental subjects to do and to treat their minds and their bodies in ways that are completely not bound to any sort of like scientific study, that's okay. Right. And so we have the fenfluramine study, we have the Tuskegee syphilis experiment, we have the story of Henrietta Lacks and her cells being taken without her knowledge or consent. We have Dr. Sims, who's considered to be the father of modern obstetrics, who performed surgical procedures on enslaved Black women without anesthesia. So
Hmm.
when we talk about like this basis of Black bodies being able to tolerate more pain, this comes directly from Dr. Sims and persisted for hundreds of years, still
Dr.
persists.
Sims was also a president of the AMA, the American Medical Association. So again, for those of you unfamiliar with, medical organizations, post
Mhm.
training, these are considered guiding lights for those after training to have the most updated information, be a part of the consensus of opinion of medical practices. So,
Mhm.
yeah, it's a pretty big deal if the president of
Right,
the AMA thinks this is kosher for all,
right.
That's purposes.
Right, right. But, we see these perceptions, these beliefs that exist today. I mean, it was just last year that there's more critical conversation about kidney function and how
Mhm.
it's actually not needing to have separate
Yeah,
measures for white bodies versus black bodies. So,
yeah,
even though yes, the 90s, I have to admit, were 30 years ago, it's not even an issue for 30 years ago. It's an issue for
no,
today. And
totally.
so then we see, okay, well, how is it that within mental health care, how do we treat people differently and assume things about black and brown bodies? And, when we think about eating disorder treatment as well, too,
Mm,
what we often see is this, massive underdiagnosis of anorexia in black bodies because the perception is, well, how could you possibly, right? Your body is curvy, your body is this, your body is that, all of these statements that are made about bodies without
yeah.
listening to the experience of the individual.
Yeah, just a reminder for everybody, right? Eating disorders are a mental health diagnosis. Mental health diagnoses are based off of thought patterns and behavioral patterns, not
Right,
body patterns or body sizes and attributes.
right,
So, truly, again, we've said it many times in these doc talks. Eating disorders do not discriminate. They exist in all races, all cultures, all ages. There isn't this, defined slice of humanity that is
right,
affected. It's
right.
literally everybody.
Right, exactly. But when we look at the diagnostic criteria for eating
Hmm.
disorders, the studies don't include black and brown bodies
Nope.
in those studies, right? And
Nope.
so the diagnoses are based upon this concept that the white body is what's considered normal. And again, we talk about history,
Mm,
right? There was the BMI came about in a really flawed way, the body mass index. Yet
yep.
we used that as part of the diagnostic criteria for eating disorders for forever. And we still use that as sort of a benchmark of whether or not you're in a body that's supposed to be the right body. But it doesn't
Totally.
take into consideration any sort of like cultural, racial, which whatever in terms of race, but it doesn't take into context anything about the individual who's sitting in front of you. Instead, it takes this
Totally.
very like Western European male body normative structure and says that should apply to everybody. And it
Right.
doesn't. It
No,
doesn't.
I mean, y'all, the world is big. The world has different body sizes, body types, um, standard or more average features, depending which part of the world you're in. So, yes, this equation again of weight over height squared made off of European white men and only some thousands, like we're still saying this is
Right.
a small n, doesn't apply to these cultures, doesn't apply to women, doesn't apply to children.
Right.
But I'm on my soapbox. I'll get off.
It's okay. But also, too, what we have to think about then is, when we're dealing with America and
Hmm.
the introduction of Black bodies with slavery, and then the intermingling of white and Black
Hmm.
bodies to create the next generation, there needed to be a way to create a differentiation. So,
Hmm.
in this more sort of like Christian culture and morality culture that existed, there was then this idea that larger, AKA Black bodies, are representing slovenliness, representing impurity, representing all of the things that run counter to being part of a puritanical society.
Hmm.
And so
Yeah.
that therefore Black bodies were deemed to be less than and less worthy and less desirable.
Hmm.
This has persisted to this day, right? Like there
Totally.
is this ideal of the body that all of us are supposed to have. And it's this thin, white ideal. And
Yeah.
there's this researcher by the name of Neha Boyle who is of South Asian descent, and she talks about sort of like the stress that South Asian women, more specifically, face in trying to achieve this thin, white ideal, and how that creates stress, how that leads then into disordered eating and eating disorders.
Totally. Totally. I mean, it is so ubiquitous. And if anything, I think you were referencing a little bit of the information and study compilation from the book Fearing the Black Body there. So really want to give a shout out. If you are looking to learn more about this, and if anything, I encourage you, anyone, whether you are in any industry whatsoever, it is really important to seek out other resources to
Mhm.
expand your impression and knowledge of this issue
Right.
specifically, and really take into stock how this is affecting multiple systems that you are likely a part of.
Mhm.
So, recommend reading that book for sure.
Yeah. Yeah.
Um, I think it's just so profoundly obvious. We talk about the systemic structural barriers to mental health
Mhm.
access, right? For individuals identifying as BIPOC. And yet ultimately, we have so much repair to do if we
Mhm.
really want to improve access to mental health care. It is on a multiple layer approach. It's not just about our clinics available with
Mhm.
appointments available that are financially accessible and in network. Um, and is the quality of care optimal versus suboptimal? It really is just simply recognizing you cannot assume you understand where someone's mental health experience is coming from, and you
Mhm.
can't automatically assume you know how to fix it either without really taking more of a curious, humble
Yeah.
um, perspective and show up for that individual of, hey, I know that there are population level, information, and I want to know your life experience. What
Mhm.
have you, what has contributed to where you are now with your perceptions, beliefs? What is your hope in even approaching care? How long did it take you to decide to have this care? I mean,
Mhm.
there's so many questions to really connect with the individual in front of you that you could not download without talking to them personally.
100%. And I think that that goes across the board, right? Because, I'll meet people every single day from all over the
Yeah.
country and ask them how they identify. And there are times where when I'm encountering somebody who's white, they say, "Oh, it's a pretty standard, normal upbringing." I'm like, "Well, tell me more about that
Yeah,
because your perception of normal may be different than my perception of
totally.
normal." And that's the first time that they've ever been questioned further about what that actually means for them.
Yeah.
Because again, there's this sort of like normalization of the white experience. And so I do try to ask a little bit more in depth about that. But then what I also will do is name systems that exist and sort of
Yeah.
say, to a person who might identify as BIPOC, I might say something to the effect of, I know that seeking mental health care as a person of a certain group might be really, really tough. And
Yeah.
I want to name that there has been harm caused by mental health care in America. What have been your experiences with that? And
Mhm.
how can we create a path forward for you to get the care that you actually need? Right. So, just even by naming that there's a system that exists, that there is harm that has been caused and may have been caused to this particular individual sitting in front of me, we're allowing space for experience to be acknowledged, to be
Mhm.
appreciated, and that
Yeah,
there is a path forward and that we don't have to constantly fight against the system that doesn't believe us.
totally. I mean, and how validating. I mean, that is it's such an inviting statement or question that you pose. And it, if anything, ensures safety as the most
Mhm.
paramount hope. When people are seeking mental health care, it usually comes down to there is this lack of safety in their very
Mhm.
existence. And
Mhm.
the defense mechanisms, neuroses, or patterns of behavior that are causing more dysfunction are then layered in there in response
Mhm.
to that lack of safety. So, if we are
Right.
really wanting as providers to help craft and create improvement around that, we have to make sure from day one that the
Mhm.
space we create, whether in person, virtual, is safe. And by
Right.
acknowledging harms, that is the first way to provide trauma informed care.
Mhm. Mhm. And I think
Yeah.
too that it's not this like algorithm, this is the way that we treat
Yeah.
X illness, right? We try this
Totally.
medicine, then this medicine, and then that. No, it really is understanding the individual, understanding what their experience has been, acknowledging, hey, that bipolar diagnosis that you got as 13 as a Hispanic
Hmm.
female, may not actually be based in reality. And so
Totally.
let's name that. Let's see what is it that you're actually dealing with, and then me acknowledging, like, look, I got to use this diagnostic statistical manual that has all the different psychiatric illnesses listed in it, and it may not actually apply to you, right? Your
Right?
experience is
Right.
not potentially encapsulated in this definition or this description of a particular illness, right? So
Exactly.
when I look at the diagnosis of anorexia, you may not 100% fit it, but that's not your problem. That's the problem of
The
the
manual.
diagnosis.
Correct.
Yeah.
The fact that it's even called the statistical manual, I mean, you and I both know in residency for psychiatry training, I mean, this is, I mean, I don't want to use this lightly, but it's the Bible. It really is the construct. We are tested
Mhm,
to like
mhm.
the minutia detail. Can we
Right.
discern between one diagnosis and the other based off of this small criteria, this small time frame
Mhm,
difference?
mhm.
And it is so interesting that now, many years in practice, it is so clear that even with population-based studies, even with the average individual experiences X outcome from using, let's
Mhm,
say, Prozac, it
mhm,
is so clear that every human body is still potentially different. And so when I'm
mhm.
working with patients, I have to remind them of that. Like, even though I have statistical data, one, I know it's not complete because of all the aforementioned reasons we've talked about.
Right.
People weren't included in these studies, and nor have they been updated to represent the current population we are serving. But
Mhm.
it also, why does it matter? Just because I say the most common side effect from using Zoloft in the first 2 weeks might be some GI distress, I'm still going to ask you, what do you feel in the
Yeah.
first week of using this medication? So,
Right.
I mean, this, I know I'm now bridging our BIPOC focus to this is individualized care, period.
Mhm.
We have been taught to try to put people into boxes based off
Right.
of aggregation of data around us when that's not healthcare,
Right. Right. 100%.
period.
And so that's why, you and I have had these really great conversations, and I'm glad that we're bringing it here, but we've had these really
Mhm.
great conversations about the need for individualized healthcare, the need to understand the individual who's sitting in front of you, their experiences, their ancestors' experiences, right? Because
Yes,
again, talking
yes,
about epigenetics, talking about the allostatic load, which is all of these, day-to-day aggressions, racism, the, structures of play and how they have to interact with them, the masking that happens of needing to
mhm.
present one way in one situation and then shifting to
To be
who you
safe,
actually are. Yeah, to be
not just to
safe.
be accepted, but to actually be safe.
Right. And how all of that then contributes to mental health and mental health outcomes.
Yeah,
Right. So it is so incredibly important to take that larger big picture as opposed to saying, do you fit this box or do you fit that box? And when you don't fit
yeah,
either, then oftentimes it is a like, that's a you problem, not a me problem. But again, right, like this is what we say about sizes of clothes. If the clothes don't fit you, that's not a you problem.
oh,
That's the size of the clothes, right?
yeah.
You are valued and whole and deserving of appropriate care, regardless of what the size of the box is.
Mm. Honestly, I think we should just end there because that was absolutely profound and beautiful and inspiring. And that is where we know we need to go
Mm-hmm.
as not just a mental health field, but a health care field on a much more larger scale. So thank you everyone for joining. This has been Doc Talk. Thank you so much, Dr. Bakshi, for joining.
Oh, it's my
And we
pleasure.
hope to have you back. All right. Take care, everybody.
Bye, everyone.